Fantastic. So what we'll do is we'll just give it a few seconds for everybody to roll in. And then once we see that there's a good majority of people in, we'll get started and stuff. Sounds good. Great stuff. We can see some people coming in now, which is fantastic. So welcome everybody. Thank you so much for joining us today. And again, thank you so much to the speakers and co-authors who are with us today as well. So my name is Nathan. I'm from the European Pain Federation, and I obviously welcome you all today. We'll be talking about a multiple method study published in the European Journal of Pain back in November next year, which explores how we explain painful non-traumatic knee conditions to adolescents. We're delighted, absolutely delighted to be joined by all of the co-authors you'll be able to see on your screen today. Morten, Malin, Chris and Henrik are here. I'll give them a chance just to introduce themselves in a second. So welcome to you all. So a little bit more information about today's webinar. Feature several presentations. I'll pass you across to Morten in a second, who will get us started with a presentation, and then we'll move through the other speakers who will have a chance to chat through. Morten will talk a broad perspective on the topics of sort of maybe 5 or 10 minutes, and then Malin and Chris will go through the study and provide the ins and outs and some discussion about it, and then we'll have some questions from you fantastic lot who are here, which is great. As I mentioned, there is like most of the webinars that we host, a Q&A function at the bottom of the screen. So where the cameras are, you can see, if you hover your mouse over, there should be a Q&A function. If you could pop your questions in there, that would be great. They'll come straight to us. What we'll do is we'll go through all of the presentations. There might be an opportunity for us to answer a couple of questions at the end of the individual presentations, but I believe the majority will probably be saved till the end so that we can have a real good discussion at the end. So please feel free to get your questions in there. They are, or they can be submitted anonymously as well. So please feel free to get them in there, all those questions that you feel might be a little controversial. We do love those. So yeah, no need to wait till the end. Get your questions in as soon as you have them, and we might answer the vast majority either at the end of the presentations or towards the end. So feel free to use that. There is a chat function as well, where there might be a few links and things that might be useful for you all today. So please feel free to check those out. Or if you want some discussion, please pop it in there as well, which is great. As usually, this is, of course, a recorded webinar and will be available to watch at a later date on YouTube and on the EFIC Academy platform as well. So if you couldn't make it today, welcome from the future. And I hope you enjoy the talk at a later date as well, which is great. So you should receive a link to access all of that. So enough of me. I'm going to hand you over to everybody just to introduce themselves nice and quickly. So Morten, good morning. Thank you, or good afternoon. Thank you so much for getting us involved. Why don't you give us a little bit about yourself?
Thank you, Nat. Yeah, sure. Thank you. And I was just going to say, if you lot who is listening want to put in the chat where you're listening from, it will give us sort of a perspective of whereabouts you are in the world. It's always nice to know. Let me just share my screen first. So welcome. Yes, I'm Morten Hu. I am a researcher from Aalborg University. I'm affiliated with the University of Aalborg, of course, where I'm an associate professor, and I'm teaching at our musculoskeletal pain program there for physiotherapists. What we are going to go through here is a research topic that we find in our group quite interesting. There will be some shared themes across it. And as Nathan was alluding to, I'll be going through some brief introductions to the topic, as it were. So let's kick off. You would all be aware, I'm sure, that you can have pain but not be injured, and you can have injury and not being in pain. This is not controversial. We've known this for years. We've begun to be more and more aware of the differences and what it means. But essentially, what we are trying to come into here is this area where we have people who hurt, where there's not this great overlap, as you see here, between for instance, the fracture and the pain, because you don't really need, there's not a lot of insecurity in giving diagnosis when it comes to these obvious examples where there's injury and pain at the same time. Rather, when we have what we, in this case, refer to as sports-related pain, just because the paper is talking about athletes, but this goes for everyone, of course, where we have maybe degeneration or we have abnormalities like spinal abnormalities, and some have pain and some don't. So we get into this area of lots of confusion and insecurity and uncertainty where we really don't know what to call things. So talk about low back pain, for instance, what is it really? Or as we will today, talk about knee pain, anterior knee pain, what does it really mean and encompass? This is from a submitted article, so it might change, but for now it's how it looks. We are trying to illustrate here that pain, rather than being this simple stimulus response system where there's an action in the nervous system that leads to a pain experience, rather than that, pain experiences are always complex, and they could be viewed, as in this case, as a puzzle rather than this simple linear or reductionist approach. Obviously, there's nociception, as you see, but there's lots of different things that actually involved in the experience of pain. And as you see, worries, for instance, or experiences, but also validation and the culture around something. So a diagnosis, to some extent, is also helping us understand what's going on. But maybe more than that, it's actually a way of communicating what is going on. And that ties into this problem, because when we don't know what's going on, then how do we give it a diagnosis? And is that diagnosis, if we give it, is it really telling us what to do with the person who's suffering? And talking about the people, this is again from an unpublished paper, so don't think that this is cut in stone, it's still in peer review. But when you have a person that feels injured, again, here we talk about athletes, but it goes for everyone. When a person feels injured, there could be a myriad of things underlying that. That could be like the flu or COVID, for instance, or an illness response, right? It could be a fracture or a rupture of some sorts, or it could be a non-pathological condition, such as non-specific low back pain, which is conceived to be much more multimodal or multifactorial as the other ones, where they are still complex, but they are driven by a clear nociceptive signal. But in all cases, an athlete in this case would feel injured. So the perception of being injured is tied into having these emotions. But interestingly, that does not necessarily correlate with being in pain. So you can feel injured and have an illness response like the flu. You see that when you look at the Olympics, for instance. A rather big percentage of those who are injured during the Olympics actually suffer from illness responses rather than tissue pathologies. And within those who have pain, again, we see there's a broad spectrum from having pain with pathology to having pain without pathology. And the place that we really understand well is this part where we could say you are injured, or we could give it a diagnosis where there's a clear correlation between what we tell you is wrong and how you feel. For instance, you have a fracture, you are injured, therefore you hurt. But as you see, it's only a fracture of the whole picture. So we need to be better at explaining this to people. There's this wonderful study done by Santoro and others, where they looked at how can we explain what people find on an ultrasound scanner in people with shoulder pain, for instance, or in this case, it's shoulder pain. And they gave them some vignettes to consider, what do you think is the best explanation, or what do you feel about these explanations? And generally speaking, when you give people a biomechanical explanation to a uncertainty problem, such as subacromial impingement syndrome, for instance, people tend to feel that they need more examinations or investigations. They feel more treatment. They need to talk to other specialists. So it drives them to have more treatment, which we have an idea is not really ideal, coming back to this concept or this paradigm of choosing wisely campaigning. On the other hand, what the study also showed, that if we only tell people that your shoulder pain is fine, just give it a bit of rest, you'll be all right, sometime later your pain will go away and you'll be like before, which is sort of, for many guidelines at least, the case. We give reassurance, as it were. It turns out that although it's better than the pure biomechanical approaches, it really doesn't solve the problem, because a lot of people don't feel that they are being heard. Rather, they feel dismissed by this idea that, well, go ahead and do your thing, you'll be fine. So we want to understand, how can we communicate this complexity and navigate people through the uncertainty? And with that, that's sort of my introduction here. That's what we try to do. As you'll see, Chris, who'll take over in a minute, is shared co-first author with Malene, who'll take over after Chris. And then Henrik, as you'll see on the pictures there as well. We don't have Michael Ratliff and Ben Darlow there, but they also co-authored the paper. And with those brief introductions, I will stop sharing my screen. If there was questions, I could take one. Otherwise, we will give it off to you, Chris. I don't see any questions.
No, fantastic for that. Yeah, just a reminder to everybody who is watching, feel free to pop your questions into the chat. It's a fantastic opportunity to have so many co-authors in the position that we have them today. So if you do have any burning questions or any questions that might facilitate a discussion, please feel free to pop them into the Q&A function. And again, it can be done anonymously as well. So please pop those on. And again, I'll hand it over to Chris for that. Thank you.
Yeah, thank you. Can you hear me? Yeah, my name is Chris, and I'm originally trained as a physiotherapist. I work as a PhD student here at the Center of General Practice at Aalborg University in Denmark. And have you shared the screen, Malene? Yeah.
Yeah, Chris, you are in presenter mode. We see your presenter mode.
Yeah, I think it's Malene who's sharing the screen right now.
Sorry, I will do like this.
Yeah.
So.
Perfect.
So yeah, it looks right now. Yeah, but thank you for giving us the opportunity to discuss our article and this important topic that Morten just outlined. This project was initiated because we recognized some challenges in how we are communicating pain, especially to adolescents. Our goal was to create some simple explanations for the knee pain, but that was also understandable based on the end user perspectives. But we also realized the complexity of this task. And this initiated a lot of discussions on the credibility, but also the effectiveness of the explanations that we provided, but also the explanations that healthcare professionals provided in their daily clinical setting. Therefore, our project aimed to address some of these challenges. Yeah, so if you change the slide. So this is the end project, but now both Malene and I will tell the story behind it and how we ended up with this explanation that looked like the figure. We decided that we needed to take a step back to examine the needs and the available knowledge, and the project expanded throughout the whole process. I think early in the process that we encountered this phenomenon, diagnostic uncertainty, which highlighted some of the challenges that Morten also presented before, where we identified some core issues that healthcare professionals had difficulties in communicating pain and the causes and how to manage it. We also saw that these labels and diagnostic uncertainty poses some difficulties, and adolescents and the parents struggled to comprehend these explanations that didn't always make sense when they was told why they were in pain. So based on this, many questions arise from that, and why is that the case, and how should we tailor these explanations? Because diagnostic uncertainty has a definition, and it's basically that you are able to explain why you are having pain, and what we could see is that those adolescents who received the diagnosis of non-traumatic knee pain, and in this case patellofemoral pain, wasn't able to explain why they are having pain. And I think that's the core issue that we try to address, where we use an data-driven approach. So the process looked like this, like the figure here, which was an iterative developmental process that involved continuously refinement and feedback, and we had regular group meetings during the whole process and between each step, and that meant that the method was also designed continuously during the development of these explanations. And now Malene will take you through some of the results.
Thank you, Chris. So my name is Malene, and I'm a research assistant at Center for General Practice in Aalborg. And I'm also a physio by training. And I've been working together with Chris and the rest of the author group on this amazing project. And I want to take you through the steps that we took to develop these credible explanations. So step one was doing the literature search, because we wanted to explore what the patients, or what already was examined about the patients, and what they wanted to know when they were experiencing diagnostic uncertainty. And after doing thematic analysis, we developed five domains that patients wanted to know about when they were experiencing diagnostic uncertainty. And the first theme was they want to understand what causes the pain, and they want to know about the different contributors to the pain experience. So it's not enough for them to just get a label or get a diagnosis. They also want to achieve some sort of understanding of the pain experience itself. It was also highlighted that the children and adolescents, they feel a high level of stigmatization for these invisible conditions. So it's difficult when they have pain that is not easy to explain to others. They do want to have a name for the pain. They want to have some sort of label or some sort of explanation for the pain, so they can use this to communicate with the peers. They also feel that it is a problem when they don't know how to control the pain, and it sort of sends them in a spiral of despair when they don't know how to sort of control their own pain experience. And we also found out that it's actually not just adults that can be critical about what the clinicians say to them about their diagnosis, as the children as well feel some sort of uncertainty regarding the message they get from the clinician. Could it be something else, even though he says or she says that this is what I experience? So we, after this step one, we drafted a first draft of our credible explanation, trying to sort of comprise all these different domains in text version. But we wanted to make it, we wanted to qualify it further, so we decided to call in help from experts, both clinical and researchers, that had experience in communicating with this patient group. So our experts, they had to have at least 5 years of clinical experience, or they had to work within the same research field as this. So they had to work within the field of adolescent pain. We included 16 participants for this online survey. And we did 2 rounds of iterations where we sent out our draft and had the experts provide feedback to our text. And we asked them not to hold back with any feedback because we could use it all, and they did not hold back at all, which led us to some different iterations. So we refined our draft and sent it out again for another round of feedback to make sure that we got all the perspectives needed to sort of how to communicate better the message we have for the children. And this led us to 4 different themes that the experts, they mentioned needed to be present in a credible explanation. They emphasize that it needs to be multidimensional. So it has to sort of involve both the psychological and the biological components, as well as the social. It needs to be tailored to the adolescents, so it needs to be written or presented in the correct language. It needs to be simple and understandable, and all the information needs to come in the correct order to create coherence in the message. It also needs to provide some validation and reassurance. So the adolescents, they get more than just the label. They also need to understand that this is what I'm experiencing, and I recognize this. And it also needs to be honest, so it can't sell any beautified pictures of the pain experience. It has to sort of bring concrete facts. And also another thing that was quite important is the wordings of the information, because it is critical not to it's critical to use some of the right wordings according to the experts in order to avoid that the messages are negatively interpreted. But of course, after revising based on the expert feedback, we had to test it on the end users, because a lot of adults can have a lot of good opinions about how we should explain things, but we need to ask the children if they understand it. So we did some think aloud sessions with adolescents to ask them if they understood the message in our product. And again, we asked them not to hold back with any feedback, and they did not. So based on their feedback, it was, for example, if if we still didn't really meet the criteria of understandability, or if there were any grammar errors, they also spotted that. And that finally led us to our final version, which we made into a graphic presentation of the credible explanation. And I'm just going to quickly run through the 3 different boxes. The first box is just mainly focused on the diagnosis itself, the etiology, and sort of diagnostic criteria, what to expect from that. And box number 2 was focused on providing some information about what can cause this pain, what different contributors are in the pain experience, to create some recognition for these children when they read it. And finally, the third box is sort of general advice on how to manage knee pain, besides any possible treatment initiatives that they will see. And these are all just general activity advice and reassuring words them. And actually, that was just about our final product. It's ended up like this. Do you have any questions?
Fantastic. Thank you so much, Malene. I really appreciate that. That's super interesting stuff. And thank you so much for going into so much detail for the methods and everything, and to Chris as well, of course, who went into detail there, which is fantastic stuff. Again, another reminder for anybody, if you would like to post some questions into the Q&A function, or even in the chat, if you feel better doing that one. There is a link to the paper in the chat, so please feel free to click on that so that you can have a look at either now or at a later date, or a quick whiz through now, which is great. We do have one question which I'd like to ask, and probably give it to the floor for anybody to kind of contribute. So it says, in your experience, is it common for, I'm guessing so, is it common for pain with non-traumatic conditions in different kinds of sport in adults, or is it only common in adolescents and in other joints? I guess conversely, how about an adolescent who has had an injury but feels no pain? Is that common? And is that something that perhaps needs to be considered? And how would you go about managing that? Perhaps the second part of the question is a little clearer. So, is it common that there's an adolescent who has an injury but feels no pain?
I can kick off. Well, we know from previous research done by Michael Ratliff and other colleagues at our university that knee pain is quite common in children. And particularly this kind of anterior knee pain is the most common thing that adolescents have. We know from other research that we and others have done that as age progresses, mid-teens, early 20s, is usually when we see a steep increase in the incidence of low back pain, as opposed to lower extremities. So it seems like in the younger generation, non-traumatic pain is more commonly seen in the under extremities, but as people age, we see it more commonly in the spine, that being neck, thorax, and lumbar spine, obviously. So that's quite common. And as for adolescents, adults with non-traumatic pain, I know it's no pain but in traumatic, but non-traumatic pain is quite common in all age groups. But as we see them differently on cohort levels at least. As for no pain in traumatic conditions, I anecdotally, obviously we know them, but I guess if we talk about pathological conditions, that's more common. So we see people with pathologies such as spinal degeneration is a common thing, right? Where people don't have pain, but they do have degeneration. Whether that's pathological or whether that is just normal aging, I guess that's a matter of words. But we see that people have degeneration that cannot explain totally why they hurt. But we see that quite commonly. Yeah, I guess that's my intro. Anybody wants to follow up, or even Dean Kali, if you want to ask any? Is it possible for them to ask it rather than write it?
I think the main function we usually just use the Q&A as they write it. So absolutely, that's probably the best way to go about this. But I'm sure you'd encourage some discussion away from here if they would like a follow-up. But yeah, Chris, Maylene, Henrik, if you have any thoughts you'd like to add to Morten's great answer there, feel free. No, fantastic stuff. So yeah, hopefully that answers your question. And again, guys, please go and get some more questions. And guys, fantastic paper. I have a few questions. Having a read through and having a listen to you guys today as well. It's some really, really interesting work, and I think we all try and think about ways that we can communicate these things better, and certainly a consideration of whether they are an adolescent athlete is important as well. I noticed that on one of your slides, although the focus is on adolescents, you have years 8 and 10 for a couple of participants, and you mentioned that you included people who were perhaps slightly under that bracket. Why did you go about including those, and how important might that be to influence the language that we use? Maylene, I'm not sure if you're looking to answer. I don't know if you're muted, but feel free to feel free. There we go.
I'll be happy to try and elaborate a little bit on that. So the thought about including some younger participants, so technically they would be called children instead of adolescents, was a way to sort of ensure that the language was understandable for the entire group of adolescents that we were sort of having as the target group, because we know there are different reading abilities in this age group. So if we made sure that it would be somewhat understandable to a younger patient group, our reflections were that it could transfer up to the next group.
No, that makes sense, and I guess it's the inherent potential of the risk of going in too high with regards to literacy. I guess the approach that you took is that if we can go as low as possible, then reduces that risk of them not understanding the information, right?
Yeah, can I chip in on that, Nathan?
Of course, please.
Because I think so. We are starting now to appreciate ideas of literacy, and sometimes when we talk about health literacy, it's almost like some people are dumb and some are not, and you need to speak to the dumber version of people as well. Whereas I think for many of us who are in this line of work, whether that be research or clinical work, we tend to believe that what we do is important. And I always like to think of accountants when I remind myself why we need to speak, at a pace and at a level where people can follow. So if I call up an accountant and ask about something about tax deduction or whatever, I don't want a long technical explanation. I just want a simple answer. If there's no simple answer, I want an understandable answer that can guide me in my behaviors, right? And I think that's really what literacy is all about. It's about giving this good sort of information so that people have the same amount of knowledge as you have, but about their condition, which enables them to then take decisions to their own part of the field, as it were. So they are able to manage their own pain, essentially, even though that will take a while. But this is beginning to communicate and let them understand where we're going.
Absolutely. And I guess it's one thing to fully understand as a clinician, fully understand the pathology and know the things that you need to explain, but being able to do that at a level that they can understand that is incredibly difficult. And perhaps clinicians are perhaps guilty of trying to, whether it's purposefully or accidentally, is overcomplicate things in order to balance being the expert in the room and the person who has this information, but also giving them the information that they can actually understand and making it as simple as possible. I guess that's a real delicate balance, right?
Yeah, and I guess first step is to realize that we don't know, and it's fair that we don't. So why do I hurt? Why does anterior knee pain hurt? We really do not know. We know that it's complicated, but we can probably come up with a good explanation to why your pain or your knee hurts, why your pain's there. Although it will not be the same as coming up with a causal explanation. And again, it ties into, I think, this idea that when we give a diagnosis, we have a stimulus response system. So treat the reason for the diagnosis, then your pain will go away. But in this whole field of diagnostic uncertainty, that's not the case. It's multifactorial. So even if we could do something to one or more of the factors, it may not make the entirety of the pain go away. And in the absence of tools that really are effective to manage pain, what we need to do is give people the ability to live their lives with as little disability as possible. Mm-hmm. And we think this is, one approach to doing that.
Absolutely fantastic. Thank you for that. We have another question. I think this is more of an example and some advice if you can. So it says, my daughter is 24-year-old dentist. Her weight is 56 kg, complaining of chronic non-traumatic bilateral knee pain with negative lab and radiological pathology. How can I explain this knee pain? How can I explain this knee pain to her?
Well, even though I wouldn't call her an adolescent, but even all the same, I think I don't know, Malene, if you could share the three explanations again, and we could just maybe quickly go through them. And maybe in all fairness, and I don't know if Chris wants to elaborate on that, but in all fairness, we or Chris and Melina and others have been looking into how do people receive these explanations, which Melina is going to show you, and not everyone thinks they're great, so they're not universally great, right? But what they might do is they might act as a sort of a guideline. So what could we do? I don't know about how people can read along. So let me just close the Q&A and I can read it out. So if we take the example with the non-traumatic knee pain, what's really important here is that we know that nothing important or nothing pathological is causing the pain. So there's nothing on x-rays. It's unlikely that there's a cancer. It's unlikely there's a fracture. If it's non-traumatic, it's unlikely there's ligament tears. With the age group, it's unlikely there's osteoarthritis. So there's a lot of things we can rule out. Of course, that needs clinical examination, but I assume that's been done. So what we do in the first case here is to talk about what is, in this case, it's patellofemoral pain, but you could replace this and say, what is non-traumatic knee pain? And what we know is that in this case, of course, some of it will be directly related, so the epidemiology is not clear, but people age 24 do hurt. Some people's knees do hurt. We don't know why, but it's not that uncommon. A soft example will be it's probably not less than about 5%, so she's not alone. And the next thing we write here is that you may feel that pain changes from day to day, perhaps even during the day, and this is normal. It's not a sign of damage to your knee. So we're trying to take that idea of reassurance, but giving it a bit of context. So talking about your knees rather than saying knee pain is not dangerous. We can perform scans, or in this case, you have had an x-ray, and it might look the same as someone who's not pain. So therefore, we know that there's nothing wrong. Like people who don't have pain have nothing wrong in their knees. You don't either. And the things that we will be worried about in your knee can be seen on an x-ray. So this gives us a lot of knowledge about what's not going on, and that's good. And also you can hurt, even though we can't see anything. That's the next part of it. So when you receive a diagnosis of, in this case, chronic knee pain, for instance, the healthcare professional is certain that there's nothing serious to your knees. And that's essentially what we do know, right? So we know there's nothing seriously wrong and nothing has been missed. If we couldn't say that, we would need further examinations. But now that we know nothing is missed, we can say that's your diagnosis. And this is where the uncertainty comes into play. And that's where the next domain is really important. So what is then causing our knee pain? And as you can see here, now we talk about children and adolescents. We can say there's a lot of young people including 24-year-olds who have pain. And they might experience it more when they load their knees, for instance, when they walk the staircases, or when they sit all day for that sake, or when they play football. So it's usually provoked easily when they're active. And it might lead some people to think my knee pain is getting worse because I'm active. But it actually seems like it's the other way around. Being inactive might be worse to some degree, but then when you move, it hurts. So, and we'll come back to the management, which is obviously to find a balance in that. And dot 3 says how much pain you feel depends on several things, and they're not always directly related to your knee. This could be your mood or thoughts, or how you see your knee and feel your pain. So these are things that, as I alluded to in the first sort of the puzzle of pain, right? There's a ton of things that can change and influence and modulate the way we feel pain. And if you have pain, anyone who's listening, if you have pain, try to notice how much that pain really fluctuates throughout the day. Even if you have like a real cause for your pain, if there's a pathological reason for your pain, it really fluctuates. Let's say I had pain, and during this talk, my pain would definitely be less because I'm focused on the talk. We call that concentration or dissociation, or we can call it a lot of things. And we know that ties into the descending modulatory system. So there's a biological reason why focusing on this would have the ability to reduce my pain. But I could have pain when I got up and walked around, in 10 minutes time. So pain is always fluctuating. And being aware of that might also open your understanding of your pain to know that it's not necessarily because you walk, but it could be other things when you walk that influence the pain. And then the third domain is about how to manage it. And that is, of course, you need to understand your pain. So you need to have a name for it. You need to be able to sort of communicate to others what it is. If you say my knees are worn, then people would say, why don't you get new knees? But if it's not what you mean, then you need a different narrative. And most people feel that pain will be worse when they move, for instance. Back pain, we know that's the case as well. Even though there's nothing in the back that is, a single cause that is leading to the pain, what we do see is that people, when they start loading their backs, for instance, on work, their backs will start to hurt, and it's the same with knees. So you need to find that delicate balance between what you can do and what you can't do. And now we're getting into the whole idea of self-management. So how can we give you information that makes you feel safe, that gives you the trust and whatever you need, guidance perhaps, to go out and test your knees? So how can you do things that you thought you couldn't do? And on the backside of that experience, well, actually, it didn't hurt any more than it would have. So I can now walk for 5 minutes, and it doesn't hurt more than if I sat still. And if you can do it for 5 minutes, then you can do maybe 7 minutes, then maybe 12, 18, 30 minutes. And you can start to have a normal functioning life. But for some people with pain, of course, and that's sort of the tricky bit about chronic pain, is that the pain may not go away, but function can still go up. So sorry, that was me rambling about, because this is something I really care about. But
No, super interesting. Thank you so much for going into detail. That's such a great model, which really makes it nice and simple, especially if you, as a clinician, if you could have that, in your desk, and you can refer to that very, very simply to relay that information to anybody who is in chronic pain. That was absolutely super useful. So thank you for that. Again, guys, please get your questions in. There's a great opportunity to speak to the authors directly if you have any specific burning questions. It's always fantastic stuff. One of the thoughts that I thought about when addressing someone as the adolescent, I believe that this is out of the scope, so perhaps maybe not much of a reference can be made, but obviously the support network that goes with people with adolescents who have chronic pain. How might this information change if we were to look to address those? And I think it was Maylene, I think part of your slides that you were talking about the concerns of adolescents who had chronic pain. it's interesting to see that none of the concerns were about their support networks, like their parents or anybody who's involved there. Was that quite interesting to see? That there wasn't really much talk about support networks and parents and coaches and managers of the sporting clubs, or was that quite interesting?
So you're referring to the initial searches we did for the adolescents, and it is actually quite interesting that it didn't occur a lot, these topics about network and sports clubs. But if you go and talk directly to adolescents, they might mention it as being one of the issues, but you have to dive a little bit deeper into it to make them talk about it themselves. And it usually comes up as an issue in terms of holding back when they have their pain. That's when the issue of, for example, sports trainers come up, because, oh, but my trainer doesn't understand it if I have to take a break or stuff like that. And I think adolescents, they just don't really like to refer to their parents unless it's because they've done something wrong. So I think that might be one of the reasons why it doesn't really come up in these interviews. And of course, I also need to maybe say that these were like a synthesis of other qualitative research that has been done in sort of different contexts. So they haven't been asking our specific question. We just did like a broad exploration of the topic. Yeah.
No, fantastic. And just thinking my clinical practice working with adolescents, one of the main questions and the priorities tends to be, well, can I play? What do I tell my coach? What, all this type of stuff. And they're usually the questions that are quite difficult, because that the information that you're giving them is probably not the information that they would want to hear, or perhaps is even going to get to them anyway. So I guess it just shows how complex the information and how they use it can be in a practical setting, right?
Yeah, and Nathan, I think there's also, so you're tapping into something, but I think we have a publication bias. I think there's not enough about it. There was just a sports conference 2 weeks ago, and it's really a thing. So we don't really know how an athlete, whether that be an adolescent or a young athlete, going about it, and it for many instances that includes work-related disability as well. It turns out to be the problem of those who experience the pain, or who have stress, or who has mental disorders, right? It's like their problem. But by seeing it that way, we also give the people with the least resources the biggest tasks to work with. And therefore, I like to say that if you're not part of the solution, you are part of the problem in this case. So whether or not there's research to support it, I definitely think that your question is valid, and it's something that should be explored in the case of single experiments, of course. But in the clinical practice, you can do that with every person you see. So I would encourage that.
Absolutely. No, that's fantastic. That's fantastic. So we have another question related again to perhaps the people who were involved in the research is which is more common in knee pain in adolescents, patellofemoral pain syndrome or Osgood-Schlatter's? I don't know if anybody wants to pick that one up, or feel free to answer that one.
Well, I think I can answer that one. So based on our research when developing these credible explanations, because we developed them for the specific diagnoses, and again, what we found was that Osgood-Schlatter disease is the more common of the two, but it seems as though that they have those with Osgood-Schlatter disease have a better prognosis compared to the adolescent with patellofemoral pain. So despite it being more common, or Osgood-Schlatter being more common than patellofemoral pain, they have a better prognosis. So their symptom duration is generally shorter than those with patellofemoral pain.
And again, here, this is all speculation, of course, but it's interesting when we have a disease that you can find on a scan and that every doctor understands and it's easy to communicate, and they're the ones with a better prognosis. Because patellofemoral pain supposedly should also be time limited, right? We say that. So when you're out of adolescence, you're more likely to not have pain than to have it. But what Michael Ratliff's studies showed earlier was that the people who have knee pain early on in school are the ones who are less likely to be physical active. And we can tie physical activity to an increased risk of having pain later in life, but also obesity and other things. So we might be tapping into this very long cascade of complex, things that happen. And it's not as simple as if you only had an experience of pain or a good explanation, we could solve it. But we do think that could be part of the way forward to have better communication abilities.
If I can just make a quick comment, it's a little bit maybe just beside the point, but I just one thing we also wanted to sort of shift the focus away from was the fact that a lot of these children, they're often told that, oh, it's just growing pains, it's just about you're just an adolescent now, so all your bones are growing and this is why things hurt right now. So we also wanted to sort of shift a little bit away from that and maybe be a little bit more concrete with the explanations we give to them. So it also, I mean, instead of just having like one broad diagnosis that they all get, like this is growing pains, then we can sort of split it a little bit more up to make it more relatable to the children. So I'm sorry, it was a little bit off topic, but something Morten said made me reflect on it.
No, that's fantastic. Thank you. Apologies, my computer decided to shut down there, so I did manage to get back in time. So I apologize to anybody if that's caused any issues. But yeah, fantastic answers. Thank you so much for addressing the questions. They are fantastic questions from everybody here. So really appreciate that. I'd like to end just on a quick one. I was itching to get back into the call because I do have one more question that I would like to ask you all. I'd love to hear kind of where we go from here. So these are fantastic ways to explain pain to adolescents. Do you have anything in plans to assess, maybe for want of a better word, the credibility of these? Do you have any plans to integrate these into some form of clinical practice or some form of trial to see how these are received in clinical practice with people with lived experience? I don't know if you have any plans, or you could explain maybe where the research is going to go from this one.
Yeah, I think I can elaborate on this. We actually already have tested some of these explanations in a clinical setting, where we have introduced these explanations to adolescents having knee pain, and the follow-up study for this article that we have talked about today was a repeated interview study where I interviewed the adolescents the days after the consultations and approximately 2 weeks after the consultation. So 2 time points for the interviews. And there we saw some of the interesting things that we saw from this study. So this manuscript is in preparation right now, but we have some preliminary data from it, and from what we saw is that what Morten talked about earlier was this concept of validation. So if you see the first sentence here, where the adolescents saw that that they were not alone, that this diagnostic label, patellofemoral pain, is actually something that exists. It's not just growing pains, like Malene just said, was actually something that worked, which was, yeah, I think it was interesting because it for me, it showed another dimension to what this label may mean. So it's not just a name; it just have some kind of validation that is accepted. So I'm not sure that was the question or
No,
the answer for the question.
absolutely. No, thank you for that. And, you know, it's really interesting and promising to see that, you know, see that this is being accepted and this is something that they understand. And obviously it's pretty obvious that it can be used and it's so practical, you know, it can be used pretty much straight away, which is brilliant stuff. Thank you so much for the questions, everybody, and the discussion. I really appreciate that. I'd love to give you it's super interesting stuff, so I'd love to give you a little platform just to kind of finish off maybe some final thoughts or some key points from this. Again, the link to the paper is in the chat, people, so please click on that and feel free to add it to what tends to be for mine a list of 20 or 30 other papers, but that will definitely be read because that's super interesting. So yes, if anybody's got any final thoughts to kind of round up the session, that would be brilliant.
I can round it off and say that we're trying to look into if we could, rather than having simple like one question and move on that, to see if we can build a platform to move on from here and apply for some funding to look into this area, because I think it's one of the more promising avenues in terms of reaching out and creating this validation, as Chris was talking about, where people feel that we actually give them the confirmation or the validation of being taken seriously, but also that your pain is there, although it may not be the only thing that worries them. There can be other things that we can deal with and manage in your life, and you are a big role in that part of that management plan. So moving towards that, maybe even taking us a little step back from being interventionalists, where we always feel like that, you know, the history taking something you just got to get over with, and then you can do the real treatment. As opposed to now, we are starting to realize how important it is to really communicate with people and to take the person in front of us complaints and experiences very, very seriously, and use them as part of the therapy as well.
Absolutely, I can reiterate that one. You know, Chris, Malene, Henrik, any final thoughts? Thank you so much for being here today. No, brilliant. Thank you so much. The information that you've given and talking through the paper and the methods and your thought process throughout the whole of the whole paper was super interesting. So thank you so much for spending time with us today, and everybody here has found it super useful, I'm sure. Just as a reiteration for everybody, this obviously was a recorded session, so you will access this a little bit later on. You can grab yourself a brew and a cup of tea and watch the reruns at a later time, either on the YouTube channel or in the EFIC Education Academy platform as well. We've covered some really interesting stuff today, so I really appreciate that. Again, Morten, Chris, Malene, Henrik, thank you so much for having us today. We really appreciate you sharing all your thoughts and your super hard work. And I think everybody should keep an eye out for the future work and the validation work that Chris was mentioning earlier as well, which would be super interesting to hear. But yeah, guys, thank you so much for hanging around with us today. We really appreciate it.
Thanks for having us. Have a good day, everyone.
Awesome. Thank you so much, guys. And yeah, have a fantastic rest of your day, and we'll see you on the next one.